Hello my friends, welcome back to Cardiac Academy. In the previous video we talked about the different types of supraventricular arrhythmias and we focused on the difference between AVRT and AVNRT. So in this video we're going to finish up the rest of the supraventricular arrhythmias. So if you're ready, let's go. Alright, so let's talk about A.Flutter. So on A.Flutter, the atrial depolarizations appear to be at a rate of 250 to 350 beats per minute, and it's usually caused by a circuit around the tricuspid valve. So in this type of arrhythmia, you will see what is classically described as a sawtooth pattern, which are flutter waves in between QRS and QRS. So these flutter waves are usually better appreciated in lead 2 and lead 3. And you're also gonna see that there's varying degrees of AB block. So on A.Flutter, all of these depolarizations are trying to make it through the AV node, but because there's a refractory period, then not all of these depolarizations are able to make it through. So the most common type of AB block is 2 to 1, but you can also see 3 to 1 and 4 to 1. So here we can see an example of that. So usually you'll be able to see flutter waves in between QRS and QRS, and if you see a QRS and two flutter waves in between QRS and QRS, that's a 2 to 1 block. If there are 3 flutter waves, that's a 3 to 1 block. And if there is 4 waves, then it's a 4 to 1 block. But the heart rate can also hint us on what type of AV block we're seeing. So if you see a heart rate of 150 beats per minute, that's usually indicative of a 2 to 1 block, 100 beats per minute, 3 to 1, and 75 beats per minute, 4 to 1. So we can see that here in this example. So here we see a QRS and a QRS, and we can calculate the heart rate. So it's 300, 150. And here we can very easily see 2 flutter waves in between them. Here, 1 and 2. So this is a 2 to 1 block. Next, we see 1, 2, 3, 4 flutter waves, and we can also calculate the heart rate. So it's 300, 150, 100, 75. And we see a 4 to 1. So here is 4 to 1. And the first one is 2 to 1. And in this final example, we can see 1, 2, 3 flutter waves. And again, we can check the heart rate. So you can see here 300, 150, 100. So 100 beats per minute correlates with a 3 to 1 block. And we can see that here. Okay, 150, 2 to 1 block, 100, 3 to 1 block, and 75, 4 to 1 block. Now, occasionally, it's not easy to see these flutter waves. So if you see a patient with a tachycardia of 150, I want you to kind of look for those flutter waves. Let's see in this example below. So here we have a heart rate of approximately 100, 150 beats per minute, but we can only see 1 flutter wave here. But if we pay close attention, you'll see there's like another flutter wave, like incomplete here. So if you can like mentally complete it, you'll see there's actually 2 flutter waves. So that's a 2 to 1 AV block. Okay, we can see that on the next example here. So we see 1 flutter wave, and if we pay close attention, there's a hidden flutter wave too. So 2 to 1. So again, you have a patient in which the nurse calls you because on telemetry the patient seems to be tachycardic, and you look at the telemetry and it's about 150 beats per minute. Look for those hidden flutter waves because there's a high likelihood they might have A.Flutter 2 to 1 block. Okay, very good. Next, we have atrial fibrillation or A.Fib. In the case of A.Fib, there's gonna be almost 100 impulses per minute trying to make its way through the AV node. So on A.Fib, we're not gonna see P waves or flutter waves. Instead, we might see what is called fibrillation waves, just like in this example. So these fibrillation waves represent all these random depolarizations occurring at the atria, trying to make it through the AV node. And occasionally some of these depolarizations will actually make it through the AV node and conduct through the ventricles. That's why we're gonna see an irregular pattern, just like here. You can see how the distance between QRS and QRS varies a lot, and that's because there's no guarantee which of these random depolarizations that are occurring at the atria is going to actually make it through the AV node. So classically on A.Fib, you're going to see it described as an irregular rhythm. In the other example, we can also see this irregular pattern. However, we don't see any fibrillation waves, okay? So A.Fib is actually much more common than A.Flutter, and it's usually caused by either mitral pathology or coronary artery disease, but we can also see it in hyperthyroidism, pericarditis, and PE. But by far, the most common cause is chronic hypertension, all right? Okay, so the next arrhythmia that we're gonna be discussed is called a MAT, multifocal atrial tachycardia. And just like A.Fib, this is also gonna have an irregular pattern, like we can see here. The distance between QRS and QRS varies. However, in this case, instead of seeing fibrillation waves, we're actually gonna see P waves, okay? We can see them here. But there's a caveat. These P waves are gonna have different morphologies. As you can see, P wave number 1 is different from P wave number 2, and P wave number 2 is different from P wave number 3, which actually defines multifocal atrial tachycardia. You need to see at least 3 different P wave morphologies, okay? So in the case of multifocal atrial tachycardia, what it occurs is that you have different foci around the atria trying to depolarize. That's why you have different morphologies in P waves. Now, multifocal atrial tachycardia is called that way if the heart rate is above 100 beats per minute. If it is below 100 beats per minute, it's called a wandering atrial pacemaker. So either MAT or WAP, okay? Very good. So, important detail, MAT is extremely common in lung disease like COPD, okay? So if you have a patient with COPD who has an irregular rhythm, look for those P waves. Don't assume it's A.Fib. Look for the P waves. If you see 3 different morphologies in P waves, you have a MAT, okay? Very good. All right, let's practice some questions, okay? So feel free to pause the video if you need more time to think, okay? So let's look at this first rhythm strip. So what type of arrhythmia are we seeing here, okay? What do you think? So we're seeing a regular rhythm, right? With a rate of about 150 beats per minute. So do we see any P waves? Not really. But what kind of arrhythmia do you think this is? So this is a supraventricular tachycardia, okay? So it's a regular rhythm, like we said. It has a rate of 150 beats per minute. And in this specific case, there's no visible P waves, but occasionally, as we discussed on the previous video, we can see some retrograde P waves, okay? Next. So what type of arrhythmia this is? What do you think? That's right, this is A.Flutter. So in this case, we see a heart rate of around 150 beats per minute with hints that is a 2-to-1 block. So this is A.Flutter with a 2-to-1 block, okay? Next. What do you think? It's an irregular rhythm, and we see fibrillation waves. So this is atrial fibrillation, correct? Very good. All right, this next one, what do you think? Again, we are seeing an irregular rhythm, but we are seeing some P waves, right? And these P waves have different morphologies. So what type of arrhythmia this is? This is a MAT, multifocal atrial tachycardia, okay? Very good. Okay, my friends, let's finish up strong by discussing some EKGs. So remember, to discuss EKGs, I want you to follow our mnemonic. The mnemonic is erratic. Let me write that down here in the corner. And just as a reminder, E is for EKG, first R is for rate, second R for rhythm, A is for axis, T is for QTC interval, I for ischemic changes, and C is for chambers, meaning hypertrophy, okay? So first, let's calculate the rate, and remember that for us to calculate the rate, there's two methods. If you don't remember, you can always watch our video on heart rate, but just as a quick reminder, there are two methods in which we can either count the number of big boxes in between QRS and QRS, going 300, 150, 175, etc. And that way we can get the heart rate. However, we need to keep in mind that for this method, the rhythm has to be regular, okay? If it is an irregular rhythm, then our calculations are going to be inaccurate. In that case, it's better to just count the number of QRSs in the rhythm strip and multiply by 6, okay? So let's look at the rhythm strip, and we can see that the rhythm is actually irregular because there's a difference in between QRS and QRS. So in this case, it's better to do the second method. So let's count the number of QRSs. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10. That's 60. 1, 2, that's 12. So we have 72 beats per minute. That's our rate. Now rhythm. Remember that for rhythm, there are 5 main questions we need to answer. First question is, are there any P waves? So let's take a look. And we see that, yes, there are P waves. Then, is there a P wave for every QRS? And we look at the rhythm strip, and yes, there's a P wave for every QRS. After that, is the rhythm regular or irregular? And we already determined it's an irregular rhythm. Is the QRS narrow or wide? It's a narrow complex QRS. And finally, is the PR interval prolonged, meaning more than 200 milliseconds? And we look and no, it's normal. So now we have a irregular rhythm in which we have P wave present sharing the same morphology. So what type of arrhythmia this is? This is sinus arrhythmia, okay? Very good, so sinus arrhythmia. And for completeness sake, let's just follow through the whole mnemonic. A is for axis, and I know we haven't discussed how to check for axis. We're gonna be doing so in on a next video, but the most important thing at this point to remember is that we want in lead 1, we want the QRS to be positive, meaning having an R wave, and on AVF we also want an R wave, a positive deflection. If they're both positive, that's a normal axis. So in this case, normal. Then T wave, what I mean by T wave in the T is QTC interval. So for us to evaluate the QTC interval, what we need to do is to look at the T wave, and we don't want it to be more than 50% in between T wave and T wave. So we can divide the distance between QRS and QRS in half, and if that T wave is more than half or at half, then it's probably prolonged. In this case, we can see it's not in between, it's not more than 50% in between QRS and QRS, so that's a normal QTC. So in this case, it's normal. I is for ischemic changes, and ischemic changes mean Q waves, inverse T waves, ST depressions, ST elevations, and we do that by looking at following anatomical region, okay? So first, I like to look at the left lateral leads, so lead 1, AVL, V5, and V6, and we look for those changes, Q wave, ST depression, ST elevation, T wave inversions. We don't see any of that. Then we look at the inferior leads, so lead 2, 3, AVF, and we don't see any of that either. And finally, we look at the anterior leads, V1, V2, V3, V4, and we see no changes, so it's normal. And finally, chambers is, we look for either left ventricular hypertrophy or right ventricular hypertrophy. And again, we're gonna be discussing this in a future video, but for left ventricular hypertrophy, we'll look for the Sokolow-Lyon criteria or for Cornell's criteria. And they are not meeting the criteria in this EKG for left ventricular hypertrophy, so that will be negative. And in right ventricular hypertrophy, the most common finding is a right axis deviation, which we don't have here. So here is normal. So in conclusion, we have sinus arrhythmia with a rate of 72 beats per minute. Okay, very good. Okay, next EKG. Again, let's follow our mnemonic. And we start with rate. We look at the rhythm strip and we see we have an irregular rhythm. So which method do we need to use? The first one or the second one? Second one, right? So we count the number of QRS. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10. That's 60. 1, 2, 3, 4, 5, 6, 7, 8. That's 6 multiplied by 8, 48. We add those and we have 108 beats per minute. Then rhythm. Do we have any P waves? Actually, we don't. What we have is fibrillation waves, right? Right here, fibrillation waves. So no P waves, irregular rhythm, fibrillation waves. What do we have? A.Fib, right? So let's write it here, A.Fib. Axis, lead 1, upright, AVL, upright. That's normal axis. T waves for QTC interval. Can we see T waves on this rhythm? We can't. We only see the fibrillation waves, so we can't really assess the QT interval, okay? I, ischemic changes. Again, we follow anatomical region, okay? So first, lead 1, AVL, V5 and V6. Do we see Q waves, ST depressions, ST elevation, T wave inversions? No, so that's negative. Then we go to the inferior leads, 2, 3, AVF. Same questions, negative. Then we go to the septal lead, B1, B2. Do we see any Q waves or T wave inversion, ST elevation, ST segment depression? So in this case, sometimes the machine might interpret this as a deep Q wave, but if we look closely, we can actually see a very tiny positive deflection there. So I will take that as an S wave, not as a Q wave, so that will be negative. Then we look at the anterior leads, B3, B4, and it's negative, so no changes. Then chambers, we look for hypertrophy. We look at the criteria. It doesn't meet the Lyons-Sokolow criteria, nor the Cornell's criteria. There's no right axis deviation, so there's no right ventricular hypertrophy either. So that's negative. So in conclusion, we have A.Fib with RVR. Why RVR? RVR stands for rapid ventricular response. If you have A.Fib with a heart rate above 100, it meets criteria for A.Fib with RVR, okay? Excellent. Okay, last EKG. Again, mnemonic. We are learning to do this in a systematic way, okay? Right, rate. Let's look at the rhythm strip. We see that it's a regular rhythm, so we can use either the first or the second method. And in this case, we can see that it's 300, 150 beats per minute. And then we go to rhythm. Rhythm, first question, do we see any P waves? And when we look here, we see something that is similar to a P wave, but then we see another kind of wave coming here. So are we really looking at P waves, or are we looking at flutter waves, right? Remember that earlier I told you that if you have a heart rate of 150, look for those flutter waves, because you could have a 2-to-1 A.Flutter, okay? So we can see here our first flutter wave, and then the second flutter wave is actually incomplete here. You can kind of complete it with your mind, and you can see two flutter waves in a heart rate of 150 beats per minute. So this is A.Flutter 2-to-1 block, okay? So A.Flutter with a 2-to-1 block, all right? Next axis, we look at lead 1, AVF, both upright, that's normal. T, we really don't see any T waves here. What we see are the flutter waves, so we can't really evaluate for QTC interval. I is ischemic changes. Again, anatomical region. Left lateral leads first. 1, AVL, V5, and V6. We don't see any Q waves, no ST segment elevation or depressions, no T wave inversions. Then we go to the inferior leads, 2, 3, AVF. And again, we don't see any of those changes. Then we go to the septal leads, V1 and V2. Again, this sometimes can be interpreted as a deep Q wave, but I'm not taking this as a deep Q wave. I'm taking this as an S wave, because if you look at V2, we can see a very positive deflection here. So I'm thinking this is probably just an S wave and a very tiny R wave, okay? So it's an S wave, not a Q wave. That's what I'm trying to say. And finally, we look at the anterior leads, V3, V4, and no changes either. Then there's no evidence for the Sokolow-Lyon criteria, nor for the Cornell criteria. Axis is normal, so there's no right ventricular hypertrophy either. So chambers are normal, okay? So in conclusion, we have A.Flutter with a 2-to-1 block with a rate of 150 beats per minute, okay? Very good. All right, my friends, that's all we have for today. I really hope you enjoyed these videos. If you do, please consider subscribing, liking this video, and sharing with your friends. And as always, I'll see you at the Cardiac Academy.